Good morning, everyone. This is Phil Pugh, Director of Emergency Management here at Memorial Hospital in Belleville. Also your coalition chair for the Hope Coalition. Thank you for joining us for our monthly meeting. This will actually act as both our monthly meeting and our quarterly meeting, since I had to take a little bit of a emergency time off to take care of a family emergency. So I appreciate your patience and understanding in that. And hopefully I gave you about an hour of your time back to do other things, but like taking care of the patients around our community here in the region. So as a reminder, please don't use the hold button so we don't get any elevator music. Please just hit mute if you're not talking in the background, so everyone can hear. All right. Our monthly reminder about the EDAP program. If you're not EDAP certified, you want more information, please contact myself, Eric Perham, or Greg, and we'll get you some information. But a great program to show that we are looking out after the pediatric patients here across our region. We'll start with our roll call with the hospitals, starting with Anderson Hospital. And I believe Eric said that he would not be able to make it today. So anyone from Anderson? All right. How about Alton Memorial?
Good morning. This is Aaron Rogers.
Got you, Aaron. Thank you. How about Boyd?
Nancy's here.
Morning, Nancy. Thank you. Carlinville Area Hospital?
Yeah, James here.
Got you, James. Anyone from Staunton? I know, again, Eric couldn't be here and he's been covering for both for a while, but just in case, anyone from Staunton? How about Fayette?
I'm here, Phil.
Got you, Tina. On the Gateway?
Danielle's on, and if Rick's not right yet, he will be.
Okay, so Rick will be showing up. I'm positive. Okay. Down to our HS partners, Holy Family.
This is Cindy from Holy Family. I'm on.
Thank you, Cindy. How about where were we at? St. Elizabeth's? How about St. Joseph Breeze?
Hi, this is Margie Berry for St. Joseph's Breeze.
Got you, Margie. And thank you. And St. Joseph Highland. Jersey
Hi, good
Community.
morning. This is Patrick from St. Joe's Highland.
Okay, gotcha, Patrick. Thank you very much. How about Jersey Community Hospital?
Yeah, this is Nick with Jersey Community.
Thank you. And from Memorial, you got myself, Mike Gilbert. I don't, Lee and Eric are out at training this week, but you also got Scott Klosterman on as well. So good to go there for both here in Shiloh. How about Memorial Hospital Chester?
I'm here. This is Georgia.
Gotcha, Georgia. Thank you.
Thanks.
OSF St. Anthony's?
I'm here. This is Denny Stanford, Phil.
Gotcha, Denny. I did get a note from Gary. He said he was having some issues getting on. Do you know if he was able to join?
I'm really not sure. I haven't even seen him yet today.
Okay, thank you.
You bet.
How about Redbud? No, Tara. And okay. How about Sparta?
This is Dale.
Gotcha, Dale. Thank you very much. And Touche Regional. Amy, are you on? I don't see you. Okay. All right, over to our health departments. Bonner County. How about Calhoun County? Clinton County. All right, 0 for 3. I think we're going to win one here. Charmaine, are you on for Eastside Health? See you on. You can just throw it in the chat. How about Fayette?
Kendra's here.
Thank you. How about Greene County?
Green's here.
Who is that?
This is Ron.
Okay, gotcha. Thank you. How about Jersey?
Heidi Carter's here.
Gotcha, Heidi. Macoupin County?
Derek here, Phil.
Gotcha, Derek. Thank you. Madison?
Michelle's here.
Thank you, Michelle. Monroe County?
Vicky's here.
Gotcha, Vicky. Thank you. Randolph County? And last but not least, St. Clair County.
Good morning, Kara's here.
Gotcha, Kara. Thank you very much. And to our community and state partners, our RMSC, Greg, you on?
I'm on, Phil.
Thank you. Our emergency response coordinator, Beth, are you on today? Okay. How about our BJC partners?
Hey, Phil, Sean's on.
Hey, thank you, Sean. Appreciate it. Any emergency management agencies?
Scott.
Okay, I got you. I got a special spot for you, Tim, but that's good. I got you. Thanks, Scott. That's Tim. That's Tim McFall for Scott Air Force Base. So, all right. Any other emergency management agencies on? No. How about our MedStar ambulance partners?
Good morning, Phil. It's John.
Yep, I got you, John. I know I saw Kelly or two in the also. So okay. How about Abbott? Abbott, nope. SLU Hospital. Helen on today. Did not see Helen. And again, our Scott Air Force Base partners, Tim McFall on. Anyone else from Scott Air Force Base on today? Nope. And our STARS partners. Anyone from STARS on? Nope. Okay. Well, we will press on. Here's our standard
Hey,
agenda. Oh, go
Phil?
ahead. Who was that? Yes.
This is Gary OSF. I'm on the phone. I couldn't access on the Teams when I'm on phone.
Okay, gotcha, Gary. I know Denny was on as well, and so I appreciate you making it through. So hopefully you got these copies of the slides. So, all right.
Thanks.
Thank you. Anyone else want to get make sure we get you captured before we move on then?
Hey, Phil, this is John Ziegler. I just I called in too. I wasn't able to get in on Teams.
Okay, thanks, John. That's my supervisor, by the way, guys. So don't make me look too crazy today. No, I'm just joking. Anyone else? All right. Today's our standard agenda. We do have a few areas that we're going to expand upon with regard to the grant status today, as well as EM resource. And then we will cover our plans. We've been talking about this. Last month was supposed to be our month where September 7th had all the plans ready and get dated for our annual review and approval from the coalition. But again, as I did have to take some emergency time off, we had to move that to this month. So we've redated all those. All right. Well, let's go ahead and get started. We'll start with IDPH. Greg?
Morning, everybody. First thing is just want to let everybody know that the IDPH Edwardsville Regional Office located in Glen Carbon has moved, and it has moved. It will become the Metro East Regional Office for IDPH, and it will be at 11 Executive Drive in Fairview Heights. I think looking at the agenda, Phil will show a picture of that. I didn't realize we were moving into the same building, but that occurred yesterday, but phone numbers are all the same. If you do, for any reason, call the office direct and somebody doesn't answer, just leave a message because they are in the middle of just getting everything moved into there right now. And that's a good move. We needed a new office. Where we're at was very old and run down. So I'm hoping this place will be a lot nicer. The other thing I wanted to, for those of you who are familiar with the CESA 988 plans, those meetings are still going on. Subcommittee meetings are occurring as well. Of course, this is to try to deal with mental health crises out in the pre-hospital setting. The thing that is probably of best benefit for the hospitals is hopefully, if this program is successful, that some of those mental health patients will not be showing up in your ED, but will have intervention done pre-hospital by crisis teams that are being set up around the state, and possibly direct admissions to other facilities besides hospitals. So that's good. They do have a deadline of December 31st. I don't know if they'll meet that deadline, but the 988 number is up and running now. And that's all I have, Phil, from IDPH.
Thank you, Greg. Really, really waiting to see how that impacts, that 988 really impacts our EMS services and EDs around. So hopefully it will do what it's intended to do. Any questions for Greg? I think someone just put something. Okay, I see Scott said that'd be fantastic. Scott works in the ED, so I'm sure he would love, he's loving to hear the progress there. Any questions for Greg? No questions? All right, and congratulations on the move, Greg. Now, when I go to the IMAX out there, I normally pass by where your office is. I go, that's where Greg works. Now, yeah, we'll be neighbors, it seems like.
Yeah.
All right. Beth, if you did join late, are you on? If not, we can go to some of the health departments. So give you a second, Beth, if you're on, there's an opportunity for you.
Yes, I'm here. Can you hear me?
Yes, ma'am. Go ahead. Thank you.
My apologies. I was in another meeting. Yes, so not a whole lot going on. Still dealing with COVID, although the numbers are decreasing, thank goodness. We are still seeing monkeypox cases in the region. So again, dealing with that. I think I sent an email out, and in case you haven't heard yet, mark your calendar. The IDPH Preparedness Summit date has been set June 6th through the 8th, and it will be in Normal, Illinois again. Not sure of the exact location, but go ahead and mark your calendars. And if you are thinking about making a presentation, let us know. We're starting to kind of put those together too. Otherwise, it's just business as usual for the health departments. Like I said, I just got on, so I'm not sure who else is on, if one of the health departments wants to add something.
Thank you, Beth. And yes, any of the other health departments want to make any announcements? Okay, hearing none, I am going to kind of put Kara on the spot. Because today, I know we've had some good interactions this morning, of transporting of a monkeypox patient and the whole TPOXX process. Are there any things that you'd like to share with regard to that, Kara, at all?
No, I mean, I walked in on that first thing this morning, as I'm sure you did. So to my knowledge, the patient had already been transported from Randolph County to Memorial.
Correct.
And they're now hospitalized at Memorial?
That's correct. That is correct.
Okay. So the information that we received is that an individual had been detained in a Texas facility and then walked with his family by foot and ended up in Sparta. And Sparta was unable to test, so he was transported to Belleville Memorial, and we kind of picked up from there with Dr. Bodeman.
Indeed.
So to my knowledge, he's still at Memorial, been for treatment.
Correct.
And testing.
Correct. And I want to thank the good folks at MedStar. I know there was a little bit of confusion last night on some of the processes, but we worked through that. And I know if John had any questions regarding this at all, because I know Chuck had been working with Mike and we worked with Ryan to make sure the medication side was going,
Right.
was picked up. But any issues with the transport, John?
No, Phil, I think some of the biggest questions is that, there's no real process out there. I think what we were more worried about is in the transport is, we knew how to take care of us, as far as our crew, but actually taking the patient from the ambulance into the hospital because he was going to a floor. So our concern was, is there a policy? Do hospitals, we haven't heard anything. And I guess what I'm trying to get to is there a policy of what we should do if we know we're coming in with a suspected monkeypox or whatever? We're pretty highly diagnosed, but I don't think there was a true diagnosis yet because of testing. But is there a policy from getting from the ER door to the floor? That was our concern about traipsing through the hospital with a highly suspected monkeypox patient.
Got it. And I think that's something that I know is probably not universally written for all the hospitals, but I'm going to double check with our nursing team here on how we're doing that. I would like to expect that it's similar somewhere between our initial COVID process and our Ebola process when getting someone to a floor, but I will have to check. And again, I don't think we have something that's directly written for monkeypox. And I'm not sure if any other of the hospitals that are on have gone down that route and have created something that's specifically for monkeypox, or maybe another. I know this is not a high consequence infectious disease, but something similar to that. So, but I will ask the question. I think it'll be good to get that dialogue started and for us to kind of, put a bow on it in the end, because I do empathize, with the understanding of, hey, I feel like we're kind of in the dark here. And maybe we are. So I'll double check. And I don't know if Scott has any insight on that. Scott, do you have any insight by chance on our processes regarding the monkeypox patient, if there's any dedicated policy? Scott, if you were talking, I couldn't hear you, but we're gonna circle the wagon on that one, John.
Yeah, again, we took as many precautions as we could, including using, the stretcher hood that actually goes over the patient. We didn't use an isolation chamber, of course, but we did try to isolate the best that we could. And again, the monkeypox has been around for a couple of months now. And again, that was just the big fear of the crew. Or not just of the crew, of MedStar, do we just come right in, just as we normally would? Again, thankfully to COVID, we knew to take the precautions.
Yep.
So we'll go with that.
Got it. And I did see your note, Scott. Thank you. Okay. Any other health department information? None? Okay. We'll go ahead and move on. Anyone from STARS join late by chance? Okay. Remert, we'll go over to Mike.
We've just been really busy the month of September. 3 out of the 4 weekends we were assisting with events. We assisted with the IndyCar race, and then we're slowing down after this weekend. We're going to be slowing down and just prepping for our big training that we're going to be doing in May.
So we had the IndyCar race. We had the marathon. What else?
We had the marathon. We had the IndyCar race. We had the Oktoberfest, and then we had Songs for Soldiers.
Great. Another plug again for Remart. Got folks that want to join and want to get involved. We could always use you.
Hey, Phil, and I'll just put out that we've been working with all the IndyCar, NASCAR, and the marathon. We've been working heavily with HSHS, St. E's, and their ED nurses. They've been sending nurses out to support us. And when we're setting up the field hospital and running the field hospital, the nurses integrate with us really, really nice, and makes for a great supplement to what we already have, to have those nurses and some of the EMS docs come out and support us. So the St. E's is really getting into supporting us when we're setting up field hospitals. So
Thanks for that. And thanks to the folks over at HSHS that are, really trying to integrate with Remart a lot. So thank you for that support, because we do need it.
Yeah, just to let you know, our new CEO, Chris Clay, he came from Breeze, St. Joe's Breeze. He is truly passionate about, offering up some assistance. It's part of our mission to provide out in the community and help where we can. So he has an incredible passion for that. So I will make sure he knows the appreciation you just threw out there.
Thanks a lot, Brad. All right. Grant status, quick grant status update. The FY23 grant is not executed yet. However, we have moved forward with some procurement, and we're getting our class schedule pretty much mapped out. We're going to be moving forward with that, again, hot and heavy. So please be on the lookout for those upcoming classes that we have. And again, for those who do have subawards, you'll have to have, until we get any other pre-authorized or pre-execution authorization for grant spending from IDPH directly, which again, they're still working on a memo to send out, that hopefully that will include our subawards to you, so you can go ahead and start spending earlier. And it may say that you can spend earlier, but just can't ask for reimbursement until the grant is executed, or until we have assigned subaward from your organization. So that's what I'm hoping that we should be receiving fairly soon. And I would say within the next 2 to 3 weeks that we should be getting that letter from IDPH. Fingers crossed, not holding my breath. But if we get that, that'll allow you guys to go ahead and get your purchases, get what you need. And then once we have that executed grant, or our executed subaward with you between BJC and your organization, then you can request for reimbursement. Some of you guys, I know Vicky's very, very familiar of that part of the process, so hopefully we'll get there very soon. And as that second bullet, you can see we're preparing to move to a new regional warehouse. So our office will remain here at Memorial, right here in the medical office building, for those of you who've been here before. But out there at 13 Executive Drive, that's where we're going to be moving. So yep, we'll be right next to IDPH. It'll be a warehouse space. It won't be nothing too fancy there, but it will be a big step up from what we've had to do, or what we've been doing over the past, I'd say 20 years, probably, as Memorial, being the RHCC and holding equipment. We've had it in multiple locations, and when COVID really hit, it showed us what we were really lacking as far as space was concerned. I mean, for those of you who've come over, I know John's been over here 1,000 times. Eric, lots of you guys have been here to pick up, good folks at Gateway, to pick up supplies throughout COVID. And depending on where that was, you could be on the 3rd floor of a medical office building, or you're going to go out to some other warehouse or somewhere inside the hospital. We're going to try to get this to a little more centralized for our equipment and supplies, and it'll be a great step up from what we have now. So once we get, I just visited there yesterday to take final look at what we're putting out there, and once it's all done, we'll put pictures together and show you what it looks like. I wouldn't anticipate us moving into the facility because they have some, I won't call renovations, putting in bathrooms, a utility room, an equipment cage, and removing the old HVAC and putting a new HVAC system in to make sure that it's temperature controlled, so we can put in some of supplies and equipment, they don't go bad. Like we have with some of our trailers in and around the region. So more to come on this, but this would be a good move for us generally. So I'm excited for that to take place. I'd say we'd probably get the keys to this maybe December, probably shooting at the beginning of the year, maybe a 1 January timeframe, but looks like around December at the earliest. All right, EM Resource. 2 things to cover here. With regard to EM Resource. As most of you know who have EM Resource accounts, whether you're a hospital or EMS, this is the location where we're, for me and Memorial as the Regional Hospital Coordination Center, when there is a disaster, when we have a tornado hit the Amazon warehouse, John Nowak will say he wants to look in EM Resource and see how many reds, yellows, and greens Anderson or OSF St. Anthony's, Jersey, or whomever can take so we can truly load balance during a disaster. That's the disaster side of it. We're going to talk about that and a few things and how we can better communicate through that system and to make sure that your team is receiving the proper notifications to get alerts when that occurs. And the second part we're going to talk about is kind of in speaking with Greg and talking with Dan Lee and crew, the second part that I want to talk about, focus on, is just those daily updates. So so we'll jump right into the disaster part first, okay? A few things. Your EM Resource notification settings inside of our EOP. Now, I've got a little excerpt. It's here. These are the folks that we said at a minimum should have access to EM Resource. Okay. Again, over the last 18 months or so, we've done exercises. Sometimes we've had less than a 50% response rate. We've had a few where we're above 80, which was great. But we do at least 6 of these a year, no notice, and they're random. I have Lee got them all programmed randomly to go at 2 in the morning, 2 in the afternoon, 7 in the morning, or what have you. So it tells you that you need to have a minimum amount of folks that have accounts. You can have as many as you want, and you guys can manage that on your own, but just at a minimum, we're asking you to have the ED director, ED manager, house supervisor, and the HPP coordinator. After that, we have a listing of what announcements you should be, at a minimum, that you should have selected in the notification preferences for EM Resource. And that's the HHS situational awareness, high priority announcements, MCI alerts, public health announcements, severe weather, and surge capacity. So those 6 areas you should have the notification preferences set so that you and or the house supervisor, ED manager, or whomever you deem need that access should be getting these announcements. So when you log into EM Resource, this is this, you'll look at this screen and over to the left, you'll see the 3 dashes and you need to get into the settings area. You want to go down there to where it says event notifications. Once you make sure that your basic preferences or your basic contact information is set, your email and your cell phone is already set up just in your your user account information, but click on that event notification. And once you click on that event notification, this page will pop up. You'll want to have each of these yellow ones highlighted. Okay, you want to have each of these yellow ones highlighted. As you can see in mine, and I've corrected mine, where it says I didn't realize I didn't have severe weather on there. So I've corrected that. I've got it on the web page, but I've got it so I get all of the announcements there now. Some of those you probably don't want to have all the time. That's okay, but at a minimum, these are the ones that you should have. And that MCI one, that's the one that's going to really, really impact us when and if there is an MCI, because whoever the triage officer is on scene needs that information, okay? And it probably takes you about 2 minutes to make updates to these. So please just go ahead in there, knock those out, and make sure you have enough folks in your organization so they're not just relying on you as potentially the HPP coordinator, but you have some redundancy there. When I look in there and I can see all the accounts across the region, most organizations have probably 7 to 10 people that have the capability to update, but they probably don't have everyone with the notification preferences to receive these event notifications. And that's where I think it's lapsing. And again, as a announcement, when we sent it out for back in December last year during the tornado in the Amazon warehouse, so once I came in and I sent out the notification through EM Resource at my house, drove into work, and then began calling folks and organizations that did not update within that first 15 minutes. I had to go down and call them one by one and say, what do you have? And then I went in there and updated it manually, because some folks were like, well, I don't have access. I would talk to a house supervisor. He or she would say, I don't have access. I've talked to an ED and they were like, I don't have access. So please make sure your folks got access, and then make sure that their event preferences are set properly. Any questions with regard to these event notification preferences? No? I would say we'll probably give a good 2 weeks and you'll get another no notice EM resource request for an MCI as an exercise. So please looking to hit above 90% response rate. Okay. Now, second thing we'll talk about is the daily bed availability status. This is what it kind of looks like right now. Anybody who's here that's where you see a red, that's anything less than 70%. If you see the 80 percentile area, that's the yellows, and all the greens are anyone above like 90%. And I think, let me just make sure I'm correct, but Fayette and OSF St. Anthony's, I think, are the only two that have all green. So I've talked with my folks here, and I've sent them emails, and we've been talking. We've transitioned how we do operations here. So I'll be completely transparent here at Memorial Hospital of Belleville and Shiloh. We've transitioned how we do things, and that transition obviously isn't going good for us because we're in the reds down here on the second half, or middle third of the year through the second half of the year. So I bring this up because this is, while it's not my baby, this is what the state uses. This is our have bed. This is what they report on every day. As you guys know, the time requirement is every morning before 10 a.m. 365 days a year, we make sure that this gets updated. I've asked everyone to have theirs updated between 6 a.m. and 8 a.m. So at least we have roughly the same information. Now, some of you may see this and go, I know we are updating this. I'm 100% positive we're updating this daily. And when I look at the numbers, there are some folks that I could probably say that, yep, that they're updating daily. And I know there's some folks on here that those numbers look about right when I would see lapses in those updates. Now, what could potentially be happening, and Greg, you correct me if I'm wrong, when we talked about this earlier, and I do have a email out to Dan Lee, is that if you are not clicking the keys, and we're going to talk about what that is here in a second, if you're not updating it a specific way, that you may, excuse me, I'm getting a call here, I apologize. Okay, if you're not updating a specific way, then your updates may not count towards your update. I know that sounds kind of odd, but that may be what's occurring. I'm not telling you that's what's happening, but that may be what's occurring. So in order to update it properly, these are the steps that you want to do. So you want to go down, once you clicked on that availability green tab, once you get an EM resource, you need to click on that set of keys that's right beside it. It's right beside your organization's name. Once you click there, it will take you to the update for that organization. And you want to click on Show All Statuses. Once you click on Show All Statuses, go ahead and hit Select All. It will transition to open up those areas in which you need to update. You go through and update the areas in which that have changed. Obviously, your daily availability would change. You make it all the way through your COVID numbers, and your capacity numbers probably stay the same or what have you. But once you've updated all those numbers, you go all the way down to the very bottom and click Save. That will ensure that you are updating it and you're getting credit. I'm using air quotes. You can't see them right now, but you're getting credit for that update. Again, I can't confirm or deny that that's not the reason, but that may be the reason. And I have a note out to Dan Lee from the state to verify if that indeed is true. What may be occurring in some instances is that some folks are clicking just directly on the individual line or the number directly, and that will allow you to change it. And it registers that you changed it. That may be occurring. I don't know if that's occurring or not, but that may be occurring, but not giving you credit. So, Greg, I'm going to pause here for a second and give you an opportunity if you wanted to relay any additional information. And then after that, any questions from the team. So, Greg?
Yeah, the only thing that I would add, Phil, to what you said, and just a slight correction, all you have to do is you don't have to hit show all statuses, just hit select all statuses. I mean, it's one less keystroke, but that's really all you have to do. So hit the green bar and then select all statuses, and then it will, select all is all you have to actually hit. And I mean, it's just one less step. If they do it the other way, that's fine too. I know we're trying to make this as easy for everybody. And yeah, unfortunately, this is the only way that when they run the report for the daily updates, that it gets counted for you. Because when you go in and just update one thing, like let's say only one thing changed, and so you just update, the report that would be run would be, they'd have to run every one of those statuses individually to see. But when you do it this way through the key, the whole report gets run for all the statuses, and then it shows that you updated all of your statuses instead of just one status. And I know Phil and I talked about this earlier. I think he's going to talk to Dan, but it is the way the system is set up.
Thanks, Greg.
But I can guarantee you that on some of you, this is the reason why. And that's because I've done some investigation. So I'll go in on a day that says you didn't update, but when I go on the individual ones, I can see that you did. So I know for a fact this is an issue for some of you. And what needs to happen really is that you, as the disaster folks, because everybody has to remember that this is part of the EMS Act. It's part of the administrative code. And in that administrative code, every hospital has to have a designated, on the lowest status, it's required to have an emergency preparedness disaster person. Our assumption is you are that person. So we really need to have you guys take this information back to the folks that are updating the system, because your hospital chose who updates this. IDPH did not designate that. So some of you have your house supervisor doing it. Some of us have your ED doing it. Some of us have your admitting office doing that. And IDPH does not know. So we really need to depend on you guys to go back, find out who this responsibility has been placed with, and make sure that they know that they need to be updating using that key for your hospital to get credit. And that's all I have, Phil.
Thank you, Greg. So yeah, I've included, so as most of you probably have seen, I sent a second email back out. I sent the one out yesterday, then I did a follow-up this morning because Greg and I spoke, and I updated these slides and incorporated at least the checklist that we developed that we use here in our hospital, and I sent the PowerPoint along with it, so you can use that as a training aid and or to change however you want to make it as a training aid or checklist for your team. And if you follow it by the letter, you won't have that issue. You won't have to worry about not receiving credit because it'll take you through the full process. So any questions from the team? Okay, hearing none, we're going to go ahead and move on to the plans update, 22 plans update. As you guys remember, this was our original timeline. We were targeting that September 7th date. So we've had, several months. You have all year to review the plans every year, but we kind of target about a 60-day window to give you to consolidate any changes required. We received a few changes, not a lot, from the coalition, and thank you for everyone who did contribute. The link that you do have, should we go through here and approve now, you can download copies of all of the plans. I have them prepared out there right now for you to download. But today's the 5th, and I'm going to give you just a quick summary of what the changes were in those plans. And these are all the documents that we did take a look at and update, sans the 5-year plan at the bottom. That's not updated, but we will discuss that. So the coalition governance documents, aka bylaws, even though we're not in a specific organization, but our coalition governance documents, the EOP, the TICP, KIMPAC, pediatric surge, burn surge, and radiation surge annex. The only change to the coalition governance documents was a removal of talking about the executive committee spending $5K in an emergency. This right here, because of how we operate as a fiduciary responsibility, this isn't something that I can just do automatically, or we can't just do as as an executive committee. We can decide to spend whatever money that we're going to decide, but it has to go through a totally another process. So this was the only thing that was taken out of or changed from what we've had before. It's been here for the past 6 years, 7 years, but just in talking with the GMO here, this was a recommendation to remove, and I didn't see any issue with removing that. The emergency operations plan, we updated the eMpower data tables and the eMpower heat map. For those of you that see the word eMpower, don't know what that is. That's basically the area or the folks that we have in specific zip codes who are reliant on some form of power because they have a medical need at home, whether it's dialysis or they need some type of breathing support, respiratory support, or what have you. And it's basically the CMS data that we show people that have. So people who have private insurance, we don't get that information, but it does kind of give you a sense of what that surrounding community looks like in your area. So we updated those with more current information. It's roughly the same, but we did find, or I found, an error in our previous version of why it wasn't like collecting, it wasn't, I guess, grouping all of the information together. So the bar graph in the old slide was slightly off. So fix that error as well. So this is a more representative bar graph once you see that in section 2. And I've also added in one of the appendixes, Appendix F there, a heat map to kind of show you around our region where the most folks who are reliant on or dependent on electricity for whatever their medical condition reside or where they're at. So you can see that pretty clear in the actual document. So that was the only real change to the primary EOP. In the KIMPAC plan, we removed all Mark 1 references and increased the target time from 30 minutes to 45 minutes. So some of you guys, well, you don't see it here. Well, remember, there's like a timeline diagram that's inside the plan. We adjusted that and the standard, I think it was in section 1 of the plan that said, the goal was to get KIMPAC assets to the scene within 30 minutes. So most of you guys, you probably reviewed the KIMPAC exercise after action report. Thanks again for everybody who participated, but that was a challenge to try to meet that. We didn't meet the 30-minute mark, but we did make it within an hour, which was good. And I think that we can probably get that down to about 45 minutes. So that was a change there. So about a 15-minute difference. Inside the TICP, this is basically an administrative change, replace the participating hospitals to regional hospitals throughout and some other minor administrative corrections. The participating hospitals kind of sounds more so like those who are grant participating hospitals. So we just changed it to regional hospitals because that makes more sense. Most folks, whether you were or are a grant participating hospital or not, you're part of the region. So that was the only change there. The pediatric surge annex incorporated this pediatric safe area checklist in Appendix B and some additional support material in annexes C through E, and added the family reception area job action sheets in Appendix F through J. So a lot more resourceful here as a document to provide you guys some form of assistance especially if you're developing your own stuff. So we put that in there so you can use that to help facilitate your own pediatric reunification processes at your organization. The radiation incident response annex, this is our initial publication of it. So thank you for everybody who did contribute to both the exercises that we ran and any review and corrections to that document. It's our first iteration of that, so thank you. And then the burn surge annex, the same thing, because we did that in combination with the radiation exercise. So thank you for everyone who participated in that as well and provided comments on the document itself. I think we got some decent starting area for both of those, and over time they'll only get better. And as you guys can probably remember, when talking about the radiation incident response annex, we said that we're more than likely, in August we talked about this, we're more than likely transitioning from an individual chemical, biological, radiological in separate annexes. We're probably going to create just a CBURN annex with some minor appendices for the future. So we have this in one document. I think we'll make better use of our time, and it'll be easier to execute with more of a CBURN annex instead of individual annexes per, hazard, so to speak. All right. Lastly was the strategic plan review. Approximately, I'm trying to think, I know Tina and Georgia, I'm trying to remember what the date was. I think it was in August. I believe it was in August. It was in August. We took a look back at our 5-year strategic plan. So the executive council got together, again, myself, John Nowak, Georgia, Eric Brandmeier, who else? Tina, Helen Sankuhl. We all got together, Greg Atterbury, and reviewed where we started, and was looking to where we're at today. So trying to look back what we've completed, and I use this each year. I just kind of go through and see where we're at and try to keep us on track. and try to target where we're going. So we're going to start to prepare our FY24 to 29. So this went FY18 to FY23. We'll be closing out the FY23 year this the end of June in 23. So we want to transition over to what we're going to go out and do in the future. And that requires not just the executive committee or executive council's insight, but everyone's insight. So we went back again, took a look at those items that we had in the short term in the plan and the long term portion of the plan. Where you see a green, we knocked that out completely, and we'll talk about what each one of those are. The yellows, some stuff that we've pretty much knocked out and that we're going to continue, and the red, maybe an area that we did not complete at all. So the increase in patient decontamination capability, increase in first responder safety and emergency operations coordination, we pretty much hit every mark that we had outlined in that plan. The regional planning, expanding coalition membership, and earthquake mitigation, we still got some work to do there, and we'll continue on those efforts. And the long-term healthcare center preparedness is an area where we're going to continue as well. So hopefully you guys can read this on your screens, if not a copy of the plan. But this is what that looked like. So we had a goal, those objectives, and what tasks required to complete those objectives, who the OPR was, and what the status was. So you can kind of review these at your leisure. But I think we did a fairly good job at getting some of this stuff done. So in looking at increasing the patient decon capability across the coalition, we did a lot of stuff there. We created the course. We got training calendars out, and we're continuously doing that. We've identified and trained instructors. We made that happen. Educated our REMERT team on the trailer and what we have. For those of you that don't know, we have a decon trailer. It's out of commission right now. We got some repairs going on it right now, but we did that. The one thing that we kind of kept open, but we considered this complete and closed, is that we do want to get kind of a more full-scale exercise. The KIMPAC exercise was a target for this, for those of you that before COVID. So April of 20 was going to be our year that we're going to knock this out, but COVID kind of derailed that. But we're gonna get that once the trailer's back up and operational. We'll get that exercise completed. Increasing responder safety and health. We really looked at some PPE areas that we were short. Procuring the fit test devices to increase our QNFT processes across the region, sending folks to training as well. Conducted the regulatory management program course. All those things, we knocked those out, completed. Increasing regional planning efforts. The only areas where we kind of fell short were the patient evacuation annex and the HCC continuity of operations plan. So we do have a requirement from ASPR to have a continuity of operations plan. We have that integrated into the emergency operations plan. If you look in the emergency operations plan, you'll look under the order of succession area, and that's where we have that information. But the executive council said basically, hey, why not just extract that information and make it its own standalone document, primarily from a audit perspective, where we can say, do you have a COOP plan? Yes, we do. Instead of showing the emergency operations plan and how we go through those orders of succession, that we just extrapolate that into something separate. So we're going to do that. I think that's something that's easy, which means we'll just, an extra page or two out of the primary EOP, which is long enough, and put that in there. And then we'll just press forward with that. And then the patient evacuation annex. We've had a draft version of the evacuation annex for quite some time. And the committee thought that, or the council said that, yeah, this is something that we still want to have. For those of you who recall, the closest thing that we've had to outside of long-term care, because we've had 3 long-term care facility evacuations since I've been here, but from a hospital perspective, the closest thing that we've had was St. Elizabeth's transition from downtown Belleville to out in O'Fallon. And that was basically, that mimicked a lot of an evacuation. And we've lots of lessons learned from that in the past, but we do believe we need something that supports a more emergent evacuation. So we're going to keep that one on the books for things to knock out. Moving over into expanding coalition membership, what you see up there in a lot of that yellow was trying to get to the point where we wanted to have a healthcare coalition that was more representative of the 17 different provider types across the coalition. I think it was at that point in time was a little lofty of a goal, a little pie in the sky, but still probably something that's needed. But it's going to take a lot of work to incorporate multiple different types of organizations outside of the core four, which are hospitals, EMS, local health departments, and emergency management agencies. Those are the core four that ASPR has said, you know, as a minimum, that needs to be a part of your coalition. This was kind of more icing on the cake. How can we get more buy-in, more support? Now, I will tell you that when COVID came around, initially, I heard from every dialysis center, every long-term care facility, everybody wanted some support, and for good reason. They wanted some support in the form of PPE, understandable. But it was very difficult to try to manage and integrate everyone. But we still think that this is something that we'd like to keep on the books and as a target for our coalition. Again, just to make it a little more well-rounded. And if that, and some of the ideas, and John or Georgia or Greg, you can stop me if you hear something different, but some of the ideas was maybe having ambassadors from one of those areas. So long-term care facilities, we'd have someone that was representing long-term care facilities that could make the meetings all the time and then provide their insight. Ambulatory surgery centers or what have you, federally qualified health facilities. I know we used to have Mike Hyman in here all the time that would represent those federally qualified healthcare facilities. But we've lost some of that kind of support over time. And that was all a little before COVID, where we still had that kind of support in some of those areas. But we still think that it's something that we can or we should be looking to increase across the coalition. If I go down a little bit further, increasing earthquake mitigation, we did a lot of that. We've maintained, we did courses, we provided training and education, and we're going to continue to do that every 3 to 5 years. So that will go into this next 3 to 5 year plan, and will be on the, not the MITEP, but the IPPM. Somebody, if you guys can remember the new names of the multi-year training and exercise plan. So we're going to continue to do that. Increasing emergency operations coordination capability. We did a lot of those things. When I'm looking at now, conduct workshop to establish those working groups. We did that. Procure COP platform. We use D4H. So we made a lot of those things happen. So those are complete wins. The areas that we kind of knocked off outside the COP was it was establishing a credentialing system. So this was something I don't think that the council wanted to continue with, and understandably, but I'll give you the vision. We were trying to get to a point where if there was an emergency, regardless of what jurisdiction it was in, we were trying to shortcut the vetting process for healthcare providers and or first responders to an incident to say that you are credentialed. So just imagine paramedic X shows up to a scene and they're able to say, hey, I am a paramedic, you know, run my license or scan this little code or what have you. And it would vet and basically say, come back with a green thumbs up from a website that says this person is good to go without worry. And trying to make that a very short process. As you guys can kind of remember through COVID, it was very difficult for a lot of just nurses to go and work in another organization. These are different challenges than what the one I'm presenting right now, but that still is a long way away. We were trying to shortcut some of that on the first responder, emergency responder side of things. So we kind of took that off. We may recalibrate and look back at that again, but we kind of pulled that out of the goals there. Establish hospital-centric talk groups on STARCOM 21. We did that. Finalized contingency communications and interoperable. We got a deployment kit. We do have an interoperable communication deployment kit that REMERT maintains. So if and when, let's say, a hospital loses all communication, that's something that we can send out. And as you can see that inside of our EOP with assets that you guys can request. And then again, down to the increased long-term healthcare facility, emergency preparedness, get them more integrated. We still think that that is something we want to continue. So that is open there. So that's a kind of wrap up of everything. Before before I move on, I'll just ask, are there any questions with regard to the plans? And again, I'll go back up to the top here. What was changed, the governance documents, any questions, concerns, about plans generally?
Hey, Phil.
Yes.
Greg. Hey, I just wanted to make one, and it can be very confusing for everybody, and it is totally fine that in the TICP and everything that participating hospital was changed to regional hospital. But I do just want to remind everybody that participating hospital in the EMS system is a legal in the administrative code designation. So if for some reason EMS would deal with you and call you a participating hospital, that's because we have resource hospitals, associate hospitals, and participating hospitals. And each one, we probably have about 10 participating hospitals. So from an EMS standpoint, you're a participating hospital. From an HPP standpoint, you're regional. So just so there's no confusion there.
Oh, thank you for that, Greg. Exactly right. Yeah, the lexicon kind of crosses over between, those lines get blurred a lot of times. So thanks for that clarity. Any other questions with regard to the plans? Okay, hearing none. Again, we don't always operate under the Robert Rules of Order, and we haven't since since I've been here. Not sure about before I got here, but we've been fairly loose with these things. But this is the one thing that I think that we always kind of do in those areas where we need to vote on something for the times that we do have to vote on things. So would someone like to make a motion to vote on these plans, to accept them as written?
Phil, this is John. I'll second that motion, Phil.
Okay, so I heard a motion and John seconds that motion, and we'll do this by abstention. Anyone not want to move forward with the plans? We'll start there. Hearing no objections, okay, the plans are accepted as written. You can, again, via that link, you can download the current copies of those plans today. So please go back and use that link that's in the presentation. And I, again, really thank you guys for the hard work and time and effort that you guys do to take to read these and provide some commentary on. Again, these are living documents. Tomorrow they can change. So if you have any requests for that, just let us know. We will update them and make sure that as long as there's not a big sweeping update that requires major overhaul, we update them and then update that exact link so you can always download the most current version on it, and we put those changes on the change log inside each plan. So all right, moving on. Okay, we're gonna open floor. Any questions, concerns from around the coalition?
Hey,
Any
Phil,
announcements? Yes, go ahead.
I just wanted to touch on one thing back on EM resource again, because it is a question that does come up. So when you're explaining to your folks about hitting the green daily updating, hitting your key, and then selecting all statuses, all the statuses will pop up. So most of the time your your ICU, your your med surge, your ED numbers will change. But as an example, most of you don't have pediatric beds, and there's a 0 in there. You do not have to highlight that and put 0 in again. You can just leave any number that hasn't changed alone and then hit save. So just so I know that question has been asked a number of times of me. So just the numbers that change, do you have to put the new number in the box? The ones that are the same, like the 0s, just leave them alone and hit save, and they will register 0 again. And that's
Perfect.
it.
Thank you, Greg. Any other announcements, concerns, questions? Okay, hearing none. Our next meeting is on the 2nd of November. Next decon class is on the 26th of this month of October. So, and I think that class is pretty much full. We'll be putting out more dates. I think we have them tentatively scheduled for February. And if you want something out at your location specifically, please just send us an email, either at info@SWILHOPE, or you can send Lee or I one directly. The IAEM, the International Association of Emergency Managers, is 11 through 17. As a matter of fact, I just registered, so I will be in attendance there, as well as the National Healthcare Preparedness Coalition Conference over in Anaheim. The courses that are on the books right now and available are the Assisting Individuals in Crisis Group Intervention, the CISM Application with Children, and Strategic Response Crisis courses. Those are available right now. You can click on the link. Those are links there. It will take you to the registration page for those. And those should be up and available right now. And as a matter of fact, let me double check them. Nope, not published yet. I'll go on there and make sure that they are published, but those links work directly there. So as soon as we are off this call, you can go there and begin to register for those classes. A reminder about your FY24 coalition proposals. You can go out there. That link is out there in Member Planet as well. And those are actually like each year, we receive less and less coalition project proposals. So there is funds available. There are funds available. So please just get them in before December 31st. That gives us enough time to make sure we get all that information consolidated. And once we have that information consolidated, we can submit it together. So I am currently making those events live, so you can go ahead again out to Member Planet and start registering here in about 15 more seconds. Other than that, I would like to thank everybody. We're going to close the meeting out here. This will be uploaded to YouTube later today, so you can watch at your leisure. So thank you guys for everything, and we'll see you next month.